Assalamu alaikum. Good afternoon or good morning to everybody who's joining us today. I'm Dr. Sohela Chima. I'm the Assistant Dean for the Institute for Population and Health and also an Associate Professor of Clinical Population Health Sciences. So a very, very warm welcome to each of you who's joining us today for our Population Health and Well-Being series. As many of you may know who attended the series before, the objectives are to discuss contemporary critical topics which are relevant to healthcare, medicine, and population health. We also examine evidence-based practices germane to public health and patient care. And we also describe opportunities and challenges in the evolving face of healthcare and population health. So just some housekeeping, your cameras and microphones have been turned off. Please use the Q&A, the question and answer feature to type questions or comments. You can also put in your comments in the chat. We will be able to see your comments or questions, and questions will be addressed at the end of the session. I will be moderating the session today. This is an accredited activity. As you know, it's accredited by both ACCME and also by the local DHP accrediting body. So you can claim up to 1 hour of your time for this activity for Category 1 credit. The post-activity evaluation will be available in your Cloud CME account by January 22nd, and healthcare practitioners who are licensed in Qatar will only receive their credits once their Qatar MOPH license number is provided. You will receive an email notification once the evaluation is available in your Cloud CME account, and your certificates will be available for download once you complete the post-activity evaluation on the Cloud CME portal. So, coming on to today's topic. Our speaker is here with us today, and it gives me great honor and pleasure to introduce Dr. Michelle Tollefson. Dr. Tollefson is double board certified in obstetrics and gynecology and lifestyle medicine, menopause certified through the North American Menopause Society, and a fellow of the American College of Lifestyle Medicine. A menopause expert, international speaker, and pioneer in women's lifestyle medicine, she is dedicated to helping women live healthier, more vibrant lives at every stage of their life. Dr. Tollefson is an award-winning professor at Metropolitan State University of Denver. She has created and oversees the world's first Bachelor of Science in Lifestyle Medicine. She serves as lead faculty for the ACLM Blue Zone certification for physicians and health professionals, and also chairs the International Competency Committee developing the Women's Health Specialty Board certification in lifestyle medicine. She is the editor-in-chief of Improving Women's Health Across the Lifespan, a co-author of Paving a Woman's Path Through Menopause and Beyond, Paving the Path to Wellness Manual and Workbook, and Paving Your Path Through Breast Cancer and Beyond. A breast cancer survivor and thriver, Dr. Tollefson continues to inspire women and healthcare professionals worldwide to reframe aging and redesign midlife as a time of possibility, purpose, and renewal. Dr. Tollefson, a very, very warm welcome to you, and over to you.
So I am honored to be here with you today as part of the Weill Cornell Medicine-Qatar Institute for Population Health, part of your Population Health and Wellbeing series. So today we'll explore the core pillars of how lifestyle medicine interact with hormonal changes to influence menopausal symptoms and risk of disease. And we'll focus on what you can do in your clinics, hospitals, and community settings to use lifestyle medicine to support midlife women. And I have no disclosures. So with that, let's begin. I was trained to deliver babies and to operate and to prescribe. What I was not trained for was becoming a patient and navigating my own menopause. 6 years ago, at age 42, I was diagnosed with a very aggressive breast cancer. Almost overnight, I went through surgical menopause, had a bilateral mastectomy, and began 16 rounds of chemotherapy. Sleep disappeared and hot flashes hit like waves, and my muscles felt like they belonged to someone decades older. And the uncomfortable truth is that even as an OB-GYN, I couldn't tell which symptoms were due to chemotherapy and which were due to menopause and what I could do about any of it. I felt confused and under-resourced. And if I felt that way, what does that mean for the women we see every day in our clinics? This hour is the roadmap I wish I'd had then, and the roadmap I hope you can take back to every midlife woman you care for. So let's zoom out from my story for a moment. Roughly 2/3 of women report feeling unprepared for menopause. Many say their symptoms were much worse than they expected, not just a few hot flashes, but significant sleep disruption, mood changes, brain fog, and pain. The emotional experience often involves fear, confusion, and vulnerability. And even when women do seek help, too many walk away without a clear explanation or plan. Women often feel dismissed rather than supported. This is not just an individual problem, it is a global issue in women's health. Midlife women are central to families, workplaces, and communities. When they're unprepared and unsupported, the cost is borne by the entire society. The good news is that as physicians and clinicians, we're in a position to change that story. Although hormone therapy is not the main focus today, I want to acknowledge that menopause hormone therapy is the most effective treatment we have for vasomotor symptoms. Although it isn't a safe option for me, for most healthy women close to the time of menopause, it is safe when appropriately prescribed for those who desire it. This is not a debate between hormones or lifestyle. It's hormones when appropriate on a foundation of lifestyle medicine for every woman. Globally, many women hear a very bleak story about midlife. You're falling apart or it's all downhill from here. That story is not only wrong, it's dangerous. It discourages help seeking and reinforces shame. I want to offer a different narrative. Midlife and menopause are not about decline, they're about design. The menopausal transition is certainly a window of vulnerability. Estrogen falls, body composition shifts, sleep can fragment, and stress reactivity increases. But that same period is also one of the most powerful windows of opportunity a woman will ever have. The habits she builds in these years will shape her risk of future disease and whether she's independent in her 80s or 90s or not. Our role as clinicians is to partner with women as they design that future. Before we talk about interventions, let's do a brief physiology refresher. Menopause itself is just one day, 12 months after a woman's final menstrual period if she goes through natural menopause. I've marked it here with that purple line. It's typically around age 50, though it varies. But the messy part, the part our patients really feel, is perimenopause. These are the years leading up to that day when ovulation is erratic and estradiol can spike high in the morning and crash later that same day. Many women think, I'm still having periods, so it can't be menopause. And yet they're already experiencing symptoms such as hot flashes, night sweats, insomnia, mood shifts, and cognitive changes while they're still menstruating. And the symptoms typically continue for at least several years after the final menstrual period, sometimes even longer. Global data show that symptoms go well beyond hot flashes. Joint and muscle pain, urinary incontinence, vaginal dryness, sexual pain, cognitive and mood problems, and dry skin are all common. When we do not name perimenopause, patients think it's just them or that they're going crazy. When we do name it, their experience finally makes sense and we can intervene. While our patients are understandably focused on symptoms, as clinicians, we're also watching their underlying risk curves. On these graphs, I've marked the final menstrual period by the purple line. Longitudinal studies show that as estrogen levels decline, women often gain weight, particularly visceral fat, which we know is the most metabolically hazardous type. At the same time, typically starting several years before the final menstrual period, we simultaneously often see a decline in lean mass. These changes are typically accompanied by worsening insulin resistance, less favorable lipid profiles, and rising blood pressure. At the same time, many women, though not all, experience drops in total energy expenditure, poor glucose control, and deterioration in bone, heart, and vascular, and sleep health. In other words, the physiologic safety net that estrogen once provided starts to fade, and vulnerability to cardiometabolic disease rises. This is why midlife is not just about symptom relief. It is a critical period for prevention. All of this physiology matters even more when we consider the broader population health landscape in Qatar. Like many high-income countries, including the United States, Qatar faces a high burden of obesity, type 2 diabetes, and cardiovascular disease. Midlife women are living at the crossroads of these trends. They're caring for children and parents, often working inside and outside the home and playing central roles in communities. If we intervene in their 40s and 50s with targeted support for movement, nutrition, sleep, stress resilience, and connection, We're not only improving their symptoms now, but we're bending the long-term risk curves. This is exactly where lifestyle medicine and Qatar's population health goals meet. Supporting women in midlife is a powerful lever for the health of families and our nation. So let's pause for a poll question. What do you think is the average global health span lifespan gap in years for women living in the 183 World Health Organization member states? So this is the number of years that women typically live with significant disease and or disability. And I'll give you a hint, it's 2.4 years longer in females than it is for males. So go ahead and vote. I'll give you a moment.
We still have responses coming in.
Okay, sure. No rush. When it seems like they've slowed down, feel free to share the results. Great, thank you. So it looks like quite a few voted for 5.43 years, 8.43, but unfortunately, the answer is 10.43 years. Let me see if I can advance to the next slide. There. So global life expectancy has increased faster than health-adjusted life expectancy, leading to a growing health span lifespan gap, which means more years lived with significant disease and or disability. Also, that gap is increasing faster globally for women than it is for men. In Qatar, the average gap for women, that health span lifespan gap, is 11.5 years. And in my home country of the United States, it's the worst of all 183 member countries at 13.5 years for women. These are not abstract numbers. These are our female patients, our colleagues, and our family members spending more than a decade struggling with limited mobility, pain, and chronic disease. Unhealthy aging in women has become dangerously normalized globally, but it's not inevitable. By focusing on midlife, particularly the menopause transition, we have an opportunity to narrow that gap for future generations of women. So lifestyle medicine offers a practical roadmap for women. Lifestyle medicine is the use of healthy lifestyle practices, including nutrition, movement, restorative sleep, stress management, avoidance of risky substances, and social connection, as therapeutic tools to prevent, treat, and sometimes even reverse chronic disease. For midlife women, they directly address the future chronic disease risk while simultaneously improving hot flashes, sleep, mood, and quality of life. Women are not asking us to fix them while they stay the same. They're asking us to help them discover how to live differently so they can step into a stronger, more vibrant future. In the remainder of this talk, we'll walk through 5 of the 6 lifestyle medicine pillars through a menopause lens, with a focus on how you can apply them for the women you care for every day. When my own abrupt menopause hit in the middle of chemotherapy, I could feel in my body what the literature describes so clearly: profound fatigue and loss of strength. The good news for me and for our patients is that one of the most powerful levers we have for improving fatigue and the loss of strength that is common during the menopause transition is physical activity. Movement is not an optional extra. It is metabolic therapy, mitochondrial therapy, and cognitive therapy that we can all use. This longitudinal study of midlife and older women reveals what happens when physical activity levels are low during the menopause transition. Menopausal vulnerabilities are amplified across multiple systems when women are inactive. The mitochondrial dysfunction that is already a vulnerability during the menopause transition is made worse by inactivity. Mitochondria become fewer in number and less efficient, producing less ATP, so less energy, more inflammatory byproducts. Clinically, that translates into more fatigue, brain fog, and low motivation. And physical and mental exhaustion are incredibly common in women. Nearly half of perimenopausal women and the majority of postmenopausal women report significant physical and mental exhaustion. This is more than just being a little tired. It's an energy crisis that affects work, parenting, relationships, and their capacity to engage in self-care. If we don't explain the why, it can feel like a personal failure. When we do explain it, it becomes a solvable physiology problem, and movement is definitely one of the key solutions. Now let's flip to the active side of the figure. On the physically active side, inflammation is suppressed, glucose metabolism improves as muscle once again becomes a powerful glucose sink, insulin sensitivity increases, and we begin to reverse the slow slide toward metabolic syndrome. Physical activity helps shift body composition, so more lean mass and less visceral fat. Also, neurons are highly energy dependent and rely heavily on mitochondria. As estrogen levels decline during the menopause transition, brain mitochondrial efficiency decreases. So a woman experiences as fatigue, brain fog, mood swings, and poor concentration. But the exciting news is that exercise upgrades the mitochondria, or the batteries that power daily life. Regular physical activity increases mitochondrial biogenesis and efficiency, so each mitochondria produces more ATP and more energy effectively. Exercise also improves cerebral blood flow and increases brain-derived neurotrophic factor, supporting mood, memory, and cognition. For the woman in your clinic who says, I just want my energy back, this is exactly what we are targeting when we prescribe movement. So what kind of movement are we talking about? For body composition changes, meta-analysis in peri- and postmenopausal women reveal a consistent pattern. Aerobic training is highly effective in reducing total and visceral fat, and resistance training is the most effective for increasing and maintaining lean muscle mass. So combined training provides the best overall results for body composition, function, and health span. Higher body fat percentage correlates with more menopausal symptoms, especially vasomotor symptoms. In one cohort, body fat explained about 42% of the variation in total symptoms. Also, the risks of low muscle mass in midlife and beyond are tremendous. An increased risk of diabetes, cardiovascular disease, and dementia, and an increased risk of losing independence later in life. Women with more lean mass have better physical functioning, and muscle mass outperforms BMI as a biomarker for overall health and a predictor of premature mortality. So for our patients, this means muscle is a vital sign. This graphic shows various trajectories that a woman may experience during her lifespan. The physical activity she engages in influences which trajectory she follows and her risk of crossing the disease disability threshold. The sedentary trajectory in red has the highest likelihood of crossing the disability dependence threshold earliest and is associated with higher inflammation and faster loss of function. The orange trajectory is for people who are recreationally active, so perhaps doing some aerobic activity, but the green trajectory, when resistance training is incorporated too, shows the greatest impact in decreasing inflammation, improving health, and delaying or preventing disability. Even small, consistent changes in movement can alter the curve of disability for decades. So how much movement should we prescribe? The physical activity guidelines for adults recommend at least 150 minutes per week of moderate intensity aerobic activity or 75 minutes of vigorous activity, plus muscle strengthening activities for all major muscle groups on at least 2 days per week. Analysis of resistance training and mortality suggests that even 2 brief resistance training sessions per week are associated with a lower mortality risk. So for time-crunched women, my practical approach is to start with 2 short strength sessions per week, each lasting about 15 to 20 minutes, using body weights, resistance bands, or free weights at home, or machines and/or free weights at a gym. When women start resistance training, it's important to emphasize safety and technique. Referrals to physical therapists or physiotherapy or beginner programs can prevent injury and build confidence. When I talk to women about starting resistance training, I emphasize that when I started to lift weights with my mom, I started very light. So that's us on the left a few years ago. We prioritized safety and form and progressed gradually. But now look at me on the right, lifting that weight. So the goal is not to turn them into Olympic powerlifters or to make them bulky. It's to build strength, confidence, and power. And if I can do it, I know other women can too. One of my favorite tools is exercise snacks, or short bouts of movement from 15 seconds to a few minutes, sprinkled throughout the day. Running up and down the stairs, doing jumping jacks, or sit to stands between Zoom calls. The data show that these micro bouts add up metabolically and functionally. And for busy Qatari women, that can be incredibly free. But knowing that exercise works is very different from doing it. Only a small proportion of women who intend to exercise actually follow through in the first few hours. For midlife and older women, perceived barriers often have more influence on whether the behavior will be continued than perceived benefits. Common barriers for women include low motivation, time constraints, lack of enjoyment, and low confidence. Many women say, I hate exercise. So our job is to help them reframe movement from something that they should do to something that she gets to do to increase her energy, strength, and independence, to really show up for her future self. To increase their chances of success, encourage women to choose meaningful, enjoyable activities, like walking with a friend or their family, dancing at home, or gardening. Research also shows that feelings drive follow-through more than facts. If activity feels like strain, like when I did that VO2 max test on the left, or it doesn't feel good or is boring, it lapses. If it feels joyful, like me jumping on that little mini trampoline that's between my kitchen and my family room, then it's more likely to be sustained. So clinically, to improve follow-through, prescribe activities and intensities that feel good now, especially for people who are new to exercise or just starting out. Tracking progress helps women see the impacts of their efforts. So invite them to track how far they can walk or how many stairs they can climb. Have them track their sleep or their energy and see how their mood responds. Women will typically notice results quickly. Social support is also a powerful performance enhancer. Women are more likely to stick with activity when they can walk with a friend or join an exercise group. Accountability, so checking in with a clinician or a coach or a WhatsApp group, can make physical activity more sustainable. So now let's move from physical activity into nutrition. Food is one of the most tangible daily levers women have to influence how this phase feels and how their future unfolds. When everything else in my abrupt menopause felt out of control, what I put into my daily smoothies became one place I could design my future and control what was controllable. And if you want my smoothie recipe, let me know at the end of the lecture. Let's start in the intestines with the gut microbiome. As estrogen levels decline, gut microbial diversity typically decreases, and we see a rise in obesogenic and pro-inflammatory bacteria. The estrobolome, so the gut bacteria that metabolize and modulate estrogen, shifts. The mucus barrier has a tendency to thin and intestinal permeability can increase, and more microbial products can leak into the bloodstream, fueling low-grade inflammation. This raises the risk for increased visceral fat and has been correlated with worse menopause symptoms. But I describe this as a midlife vulnerability. It is not inevitable. Through healthy food choices, we can support a healthier microbiome, even in the context of hormonal change. The second major nutrition focus for our midlife patients is energy needs. During the menopause transition, resting energy expenditure drops by about 300 kilocalories per day for many women. Same intake, same activity, and the scale quietly creeps up. When women respond with aggressive calorie restriction or very low energy diets, we see more fatigue, mood changes, sleep disruption, and even worsening hot flashes. They lose muscle, not just fat. Their metabolism slows, and metabolic health often worsens. So our aim is strategic nourishment, improving diet quality so that fat mass can decrease while lean mass, energy, and function are protected. Now let's connect nutrition to one of the most common perimenopausal complaints, persistent fatigue. When women eat very large amounts of foods in a single sitting, or meals high in sugar and saturated fat, so think multiple sugary drinks, sweets at the end of a stressful day, or a very heavy late night meal, mitochondria become stressed and inefficient. They have to work overtime to store the incoming calories, sugar, and fat. The result is less ATP, more inflammation, and an energy crash. Women often struggle with fatigue, a lack of motivation, and mood problems. So I like to frame fatigue as a distress signal. Yes, we need to rule out medical causes, but often fatigue is a message that diet and lifestyle need to better support mitochondrial energy production. In terms of eating patterns, many styles can support a healthy menopause transition. For women in Qatar, the goal is not to make every woman eat one specific type of diet. It's to apply the same evidence-based principles to familiar, culturally meaningful foods. A traditional Gulf-style pattern before the recent rise in ultra-processed foods was naturally rich in vegetables, fruits, whole grains, legumes, herbs, fish, and other seafood, modest proportions of lean meat, and unsaturated fats from oils, nuts, and seeds. When we emphasize these foods and reduce heavily processed items, so sugar-sweetened beverages, excess saturated fat, we see the same benefits demonstrated in large international cohorts: less visceral fat, better metabolic health, and healthier aging in women. The Nurses' Health Study and Health Professionals Follow-Up Study, which followed more than 100,000 adults, 2/3 of them were women, for 30 years, showed that a higher adherence to a variety of healthy dietary patterns that were rich in whole and minimally processed foods and an abundance of plants was associated with higher odds of healthy aging, so living free of major chronic disease and preserved cognition and physical function. And the effect was even stronger in women than it was in men. The foods that stood out across studies as especially beneficial were fruits, so especially berries, vegetables, especially leafy greens, whole grains, legumes, nuts, seeds, and low-fat dairy for those who use it, and especially unsaturated fats. Unsaturated fats, like those from extra virgin olive oil, nuts, seeds, and avocado, are strongly associated with survival to older ages with intact physical and cognitive function in women. On the other hand, dietary patterns high in red and processed meat, high in sodium, and especially ultra-processed foods are linked with lower odds of healthy aging in women, worse physical and cognitive function, and more chronic disease. In many high-income countries, including in the Gulf region and in the United States, increasing intake of ultra-processed foods and sugar-sweetened beverages is a growing concern. One simple high-impact lever is fiber. For most midlife women, I recommend aiming for at least 25 to 30 grams of fiber per day from whole and minimally processed foods. Practically, that means building meals around vegetables, fruits, whole grains, legumes, nuts, and seeds. I often invite women to track their fiber intake for just 3 days and then reflect, how close am I to 25 to 30 grams? What could I add? Or is there a place I could add one more vegetable or whole grain? This simple experiment increases awareness. Emphasizing the color on the plate also reinforces the importance of phytonutrients, or the plant compounds that work alongside fiber to reduce inflammation and support brain, heart, and vascular health. Now, many women ask me about soy. Soy foods like tofu, edamame, and soy milk are rich in weak phytoestrogens. In food form, not supplements, they're linked with healthier gut bacteria and lower cardiovascular risk. And one research study showed that women who ate about a half cup of cooked soybeans daily had significantly fewer hot flashes. Regardless of their impact on hot flashes, moderate intake of soy foods can be a safe part of a heart-healthy, plant-forward eating pattern, even for breast cancer survivors like me. Fermented foods such as plain yogurt, pickled vegetables, and olives support a more diverse microbiome and may help with inflammation, metabolic health, and even mood, which is so important in perimenopause. A simple prescription is, let's aim for 1 serving of fermented food most days. Just watch the added sugar and salt that comes along with some of them. Now, ground flaxseed is one of my favorite menopause foods. It combines plant-3 omega-3s, fiber, and lignans with mild estrogen-like activity. Studies suggest benefits for lipids, metabolic health, and possibly hot flashes, mood, and constipation. I often suggest trying 1 to 2 tablespoons of freshly ground flaxseed a day, sprinkled over oats, mixed into yogurt, or blended into a smoothie, like my smoothie that's sitting right over there. Now, protein is another key story in this life stage. With age and during the menopause transition, women experience anabolic resistance, making it harder to maintain and build lean muscle mass. Protein is essential for preserving muscle and bone, supporting a healthy body composition, and contributing to neurotransmitter production, mood, and sleep. Survey data suggests that many midlife women undereat protein, especially at breakfast and lunch, which is unfortunate since women who are wanting to improve their body composition, which is the vast majority of midlife women, benefit from a baseline target of 1.2 grams per kilogram per day of protein. This is especially important for women who are under physiological stress, have a chronic illness, are trying to lose weight, or are doing resistance training, which once again, I believe every midlife woman should be doing. I suggest that women track their protein for a few days to see where they're at, and then if they're below 1.2 grams per kilogram per day, try to increase it to 1.2 grams per kilogram per day and track how they feel. One large cohort of nearly 49,000 women followed for 3 decades looked at how different types of protein in midlife related to healthy aging. So defined not just as the absence of disease, but also good physical function, cognition, and mental health. So let's pause for another poll question. So in this study, what type of protein do you think had the strongest association with healthy aging? So go ahead and take a moment to vote. Do you think it's total protein intake, or animal protein, dairy protein, or plant protein? The strongest association with healthy aging for women.
Answers are still coming in.
Sure. It's still morning here, so while that's happening, I'm going to take a sip of my smoothie. Are you able to show the results now? Does it seem like most have come in?
Yes.
Oh, so very well distributed. Thank you. So it looks like total and plant were both in the lead, maybe followed by animal and then dairy. Thank you for voting. So the answer is plant protein. Although more protein of any type was linked with better odds of healthy aging, the strongest association was with plant protein. So the key message for our patients is not high-protein dieting, but gentle substitution. For counseling, that means encouraging more lentils, chickpeas, beans, and nuts as women move through perimenopause to increase their chances of healthy aging. This prospective cohort study that included 175,000 women and followed them for 24 years found that a higher total animal fat intake was associated with higher all-cause mortality in a dose-response relationship. They found that replacing even 5% of daily calories from animal fat with plant fat was linked to a 5 to 30% lower cardiovascular mortality and a 4 to 24% lower all-cause mortality. This study showed that a 5% substitution of calories from animal or saturated fat with calories from vegetable and monounsaturated fats was linked with a 15 to 48% lower risk of dementia. So again, instead of red meat, processed meat, butter, and high-fat dairy, encourage extra virgin olive oil or avocados, nuts, seeds, and soy foods. And if someone wants to eat fish, then fatty fish. So in practice, I encourage women to build meals around a protein anchor and aim for roughly 25 to 30 grams of protein at each main meal with smaller protein-rich snacks. Chrononutrition is another powerful lever. It's not only what women eat that impacts health, it's also when. Consistent meal timing helps synchronize circadian rhythms and supports metabolic regulation. Many midlife women fall into a pattern of skipping breakfast, eating little during the day, and then consuming most of their calories in the evening. I suggest shifting more of their calories earlier in the day and easing up at night when they can. So for many, that means a 10 to 12-hour daytime eating window, a substantial breakfast with protein and fiber, and a lighter, earlier evening meal. Finally, behavior change must be compassionate and realistic. Many of our midlife patients are exhausted, time-pressed, and carrying a heavy mental load. They do not need perfection. They need small, culturally aligned levers. We might start with add one additional vegetable to lunch and dinner, swap one sugary drink for water, unsweetened tea, or a less sweet version, or include a protein anchor at breakfast most days. Group medical visits and collaboration with dietitians can reinforce these changes. So that's nutrition as lifestyle medicine, not a diet to endure, but a daily way to design the future and support thriving through midlife and beyond for women. Now I want to turn to the pillar that challenged me the most during abrupt menopause, sleep. During chemo and surgical menopause, it wasn't just the fatigue and brain fog that wore me down. It was the 2 a.m. wide awake nights with my mind racing. And our patients live versions of that story every night. Sleep problems in the menopause transition are multifactorial. As estrogen declines, night sweats increase, and progesterone with its naturally calming effects falls. Cortisol and stress reactivity tend to increase and sympathetic tone rises. Melatonin secretion decreases, and visceral fat-driven inflammation adds fuel. The result is difficulty falling asleep, fragmented sleep, and early morning awakenings. So it's not just a few night sweats, it's an entire system in flux. Sleep problems are much more than a nuisance. In the SWAN cohort, when researchers applied the American Heart Association's Life's Essential 8 framework to midlife women, sleep emerged as the single strongest predictor of both cardiovascular events and all-cause mortality during the menopause transition. Sleep is a clinical tool, not a luxury. Protecting sleep is as important as addressing blood pressure or lipids. Sleep is tightly linked to weight and appetite as well. When sleep is disrupted, leptin, or the hormone that signals satiety, decreases, and ghrelin, the hormone that stimulates hunger, increases. Brain reward centers become more responsive to highly palatable, energy-dense foods. Research shows that with insufficient sleep, even if women lose weight, they're more likely to lose lean mass and less likely to lose fat. And this can be a powerful physiology-based motivator for women to prioritize sleep. From a brain perspective, sleep is when the lymphatic system clears metabolic waste, such as beta amyloid and tau, from neural tissue. Chronic sleep deprivation is associated with increased dementia risk. In the SWAN cohorts, the study of women's health across the nation, that cohort, about 2/3 of women reported memory complaints during perimenopause. When sleep is deficient, we see impaired memory and attention and slower cognitive processing. When women describe brain fog, I often say one of the most powerful things we can do for your current and future brain is to protect your sleep now. So how much sleep should we aim for? Across multiple studies, about 7 hours per night appears optimal for cognitive and mental health and for preserving brain structure, with a recommended range of 7 to 9 hours. Consistently sleeping less than 6 hours or more than 9 is associated with higher risks of depression, cardiovascular disease, and cognitive decline. So how do we help our patients? First, we screen for sleep disorders that increase during the menopause transition, such as sleep apnea. For chronic insomnia, cognitive behavioral therapy for insomnia is first line. Cognitive behavioral therapy for insomnia retrains the brain to associate bed with sleep, consolidates sleep by limiting time awake in bed, and addresses unhelpful thoughts like, if I don't sleep now, tomorrow will be ruined, and builds a more flexible, realistic relationship with sleep. Lifestyle pillars also shape sleep. Nutritionally, nutrient and fiber-rich eating patterns, so abundant in whole foods and unsaturated fats, are associated with better sleep quality. In contrast, diets high in saturated fat and ultra-processed foods and added sugars, especially late at night, tend to worsen sleep. So in Qatar and the United States, heavy late-night meals, very sweet drinks, and 24-hour food delivery can make it easy to push most calories into the late evening. Now, physical activity and sleep have a reciprocal relationship. Regular movement during the day improves sleep onset, depth, and continuity, especially in midlife women who struggle with sleep, and reduces symptoms of insomnia. So even in midlife women with busy schedules, encouraging a short walk after work, climbing the stairs, or doing a brief home strength routine can support sleep. The key message to our patients is that the body sleeps better when it has been asked to move during the day. Mindfulness and relaxation practices are not just extras. They are evidence-based adjuncts for sleep in peri- and postmenopausal women. Techniques such as diaphragmatic breathing, body scans, and progressive muscle relaxation, guided imagery, and brief meditations can help downshift the nervous system before bed. Finally, light is medicine for the circadian system. Bright, natural light in the morning and during the day strengthens circadian rhythms, improves alertness and mood, and anchors sleep timing. Dimmer, warmer light in the evening, so less screen exposure and harsh overhead light, signals the brain that night is coming. Even a few minutes of outdoor light most mornings, even if it's just on a balcony or walking briefly between buildings, can strengthen the circadian rhythm. Then start dimming lights and screens about an hour before bed. As clinicians, when we address hot flashes, mood, weight, and cardiometabolic risk in midlife women, we also need to prescribe sleep. A good night's rest is one of the most potent stress resilience and brain health interventions we have, and one of the pillars we can most tangibly support. Now let's move on to stress. Globally, midlife is one of the most, if not the most stressful time in women's lives. They're often caring for children and aging parents, managing demanding careers, contributing to extended families, and navigating social and cultural expectations, often while staying engaged in their communities. All of that collides with the hormonal shifts of the menopause transition, creating a perfect storm that can challenge even the most resilient women. Menopause does not create stress out of nowhere, but it does turn up the volume on the stress women are already carrying. As estrogen and progesterone fluctuate and then decline, especially progesterone, which has naturally calming effects, the stress system becomes more sensitive. Emotional dysregulation and vulnerability to mood disturbances increases, particularly in women with a history of anxiety or depression. And autonomic balance shifts as well. Compared with premenopause, perimenopause is characterized by higher sympathetic activation and lower vagal tone. Sympathetic tone increases even more postmenopause. So I frame this as a vulnerability, not an inevitability, because there's much we can do to influence it. A helpful way to visualize this is with these little diagrams that I used to draw on the back of my paper charts. Let's talk about the stress tolerance platform. Before menopause, it's like that platform is wide. Daily hassles and even significant stressors happen, but it takes a lot to push a woman over the edge into what the literature calls an unwanted stress reaction. Life is not easy, but there is more buffer. As women move through perimenopause, that platform narrows. The same stressors like work deadlines, caregiving, relationship strain can more easily push them closer to the edge. Smaller triggers can produce bigger reactions. The platform eroders or allostatic load include the unhealthy lifestyle factors we've already been discussing. So poor nutrition, physical inactivity, inadequate sleep, risky substance use, and the lack of social support. High allostatic load also exacerbates vasomotor symptoms, sleep disturbances, depression, and anxiety. High chronic stress makes everything worse. The goal of lifestyle medicine is not to eliminate stress, it's to widen the platform again. The platform builders are the same healthy behaviors we've been discussing: nourishing food, regular movement, restorative sleep, avoidance of risky substances, and supportive social connection. We can also add mind-body practices and spirituality or meaning practices, which are deeply embedded in Qatari culture. A sense of purpose and positive attitudes toward menopause and aging also help build resilience. So this is good news for our patients. There are concrete actions they can take to increase their resilience to stress. Stress and mood shift together. Network analysis shows that the most prevalent experiences reported during the menopause transition are tiredness, excitability, and irritability. Globally, these are often minimized as just moodiness, but they are core perimenopausal experiences that often negatively impact quality of life for years. Social media has popularized the phrase tired but wired, and many of our patients recognize themselves in this phrase. Understanding that these patterns have a biological basis allows us to say, you are not broken, your system is overloaded. Let's explore how to lower your stress load and support your system. From an energy perspective, chronic psychological stress is demanding. It impairs mitochondrial function at the very time mitochondria are already vulnerable to hormonal change. The combination creates an energy mismatch. Demand exceeds supply. The result is exhaustion, decreased motivation, difficulty initiating healthy behaviors, and increased reliance on quick energy fixes such as sugar and caffeine. We also see more muscle breakdown and accelerated cellular aging. Interventions that decrease perceived stress signal to the body that resources are available so it does not need to stay in a state of chronic threat. Deep rest and better sleep, meditation and paced breathing, nourishing high-quality food throughout the day, appropriate but not excessive physical activity, and plenty of social connection are all cellular energy interventions, not just wellness extras. Sleep and stress resilience are inseparable. Sleep deprivation amplifies amygdala reactivity, weakens prefrontal cortex regulation, and makes minor stressors feel overwhelming. Adequate, consistent sleep is a stress resilience multiplier. It helps women regulate emotions, think clearly, and cope with demands that we cannot remove. When we are helping a woman with stress overload during the menopause transition, we need to help her optimize her sleep. And physical activity is one of the most effective behavioral tools we have for modulating the stress response. Regular movement improves autonomic balance, reduces sympathetic overactivation, and enhances vagal tone, allowing the body to recover from stress more efficiently. It helps clear stress hormones such as cortisol and catecholamines, and exercise trains the stress system to be more resilient. Mind-body practices such as yoga, tai chi, Pilates, and Qigong can also help with stress reduction. Randomized trials in peri- and postmenopausal women show improvements in stress, mood, and energy with these practices. Cognitive behavioral therapy is another powerful tool for stress resilience. It helps women reframe unhelpful thoughts about menopause and aging, develop more adaptive coping strategies for symptoms, and regain a sense of control. The Menopause Society supports the use of cognitive behavioral therapy for women who want help with vasomotor symptoms and mood, including those who prefer to avoid hormone therapy or are not candidates for it. Even self-guided cognitive behavioral therapy programs and books, like the one shown here, have meaningful benefits, with many women reporting improvements in vasomotor symptoms, coping, and quality of life within weeks. We cannot remove all our patients' stressors. However, cognitive behavioral therapy and lifestyle foundations can help women weather the stresses of midlife. Helping women understand the narrower stress resilience platform of menopause, validating women's experiences, and then co-creating one or two realistic resilience-building practices can be powerful. That's how we help women move through midlife and menopause with a wider, more stable platform to stand on. So we've discussed movement, food, sleep, and stress resilience, but another pillar we cannot afford to overlook in midlife is social connection. It's very common for perimenopausal and postmenopausal women to be surrounded by people, yet still feel alone. They may have colleagues, a partner, children, aging parents, neighbors, and hundreds of social media contacts, yet feel like they have no one with whom they can be honest about brain fog, hot flashes, or fear of aging. Also, the quantity of a woman's contacts does not equal the quality of her social support. What matters most for health is perceived high-quality support, so people who listen, validate, and stand beside her. Strong social support is associated with higher life satisfaction, better psychological well-being, healthier behaviors, and even lower mortality risk. For women in Qatar, social networks are often rich and multi-generational, with deep ties through family, faith, and community. And those are powerful assets. But many women still tell us that they do not have a comfortable space to talk honestly about menopause. Our role as clinicians is to name social connection as a healthy pillar and to help women identify and strengthen the relationships that truly support them. When researchers ask midlife women what they want from menopause care, the answer is remarkably consistent. In one cohort, over 80% were interested in a structured lifestyle program to ease menopausal symptoms, and more than 75% preferred to participate with other women in a similar life stage. They wanted help with weight, hot flashes, sleep, mood, and sexual health, and they wanted to use food, movement, and stress management to feel better. The message is clear. Women want evidence-based lifestyle medicine education in a community of their peers. A systematic review of randomized menopause interventions shows a clear pattern. When clinicians deliver evidence-based education on nutrition, movement, coping, and sexuality in a supportive group setting, women experience broad benefits. These programs reduce vasomotor symptoms, anxiety, and depressive symptoms, and improve cardiometabolic risk and quality of life. So information alone is not enough, and support without guidance is not enough. The combination, structured lifestyle medicine content plus the chance to learn and talk with other women who are in midlife or menopause transition, is especially powerful. In Qatar, these principles can be applied in many ways, from brief women-only education sessions in primary care or hospital clinics to group women's health programs. 6 years ago, after finishing chemotherapy and entering menopause abruptly, I joined an online shared medical appointment for breast cancer survivors. I entered the Zoom room scared, needing someone to connect the dots for me and offer evidence-based hope with practical advice. That group shifted my own health trajectory through the power of lifestyle medicine, and I've watched lifestyle medicine shift the health trajectories of other women around the world. Women like me, and like so many of your patients in Qatar and across the Gulf, are exhausted. They're navigating midlife symptoms, stress, caregiving, careers, and constant demands, all while being bombarded with conflicting advice and false promises from people eager to profit off their menopausal symptoms and confusion. Our patients are doing their best, but they could benefit deeply from the grounded evidence-based wisdom and tools that we have to share. That's why we're here. None of us can do this alone. We need each other if we're going to change the story of menopause care for women in Qatar, the Gulf, and globally. Globally, we're entering a new era of menopause and midlife care. It's not about denying aging, it's about redefining it, moving from fear to empowerment, from decline to design. Menopause is not the end of vitality. It's the beginning of a conscious redesign of how we live, move, eat, connect, and rest. As I shared earlier, women in Qatar spend about 11 and a half years in poor health, often driven by non-communicable disease. That's an injustice, and it's changeable. Lifestyle medicine provides us with both the evidence and the community to close the health span lifespan gap so women can not live just longer, but they can live stronger, more connected, and more alive. Yes, menopause is a window of vulnerability, but it's also one of the greatest windows of opportunity a woman will ever have. In this season, minor lifestyle changes yield outsized returns to build and protect muscle, nourish the gut microbiome, restore sleep, decrease stress reactivity, and deepen connection and meaning. The true leaders of this new era of menopause and midlife care is each of us who chose this work. We are evidence-based clinicians who want to heal. We're healthcare professionals who believe that how we live, how we eat, move, sleep, connect, and find meaning can transform health for the women we serve. In this new era of menopause and midlife care, we replace shame with science, confusion with clarity, and silence with connection. So here's my challenge. At your next visit in clinic with a midlife woman, name perimenopause or menopause, normalize it, co-create one small lifestyle experiment that fits your patient's life, and schedule the follow-up. One lever, pulled gently but deliberately. Each conversation is a spark, and together those sparks will create a new era of menopause and midlife care for women in Qatar and globally. Together, let's redefine aging, one conversation, one experiment, one woman at a time. Thank you so much for your attention. I will stop sharing, and I'm happy to take any questions.
Thank you so much, Dr. Tollefson. That was a wonderful, wonderful session. I think really an eye-opener. We've received a lot of comments appreciating what a great session it was. And we've got a lot of questions also. So I'm just going to go ahead and start so you can try and address as much as you can for our audience. Yes. Okay, so I'll just go through sort of in the, how it is there in the order. So basically asking about if there's any evidence-based recommended antioxidants to assist with free radicals caused by hot flashes to reduce the effects of menopause. Any thoughts on that?
Yeah. So yes, thank you for that question. Great question. I am a food first person. So a diet. So while there are like supplements and multivitamins, Diet first is how I think that the evidence really shows we get the most benefit. So
Right.
prioritizing a diet that's rich in antioxidants. So again, all of those things that we see, the fruits and vegetables and whole grains and nuts and beans and seeds, all of those high antioxidant foods will, I believe, be overall better for health in the long run than trying to target it with one specific supplement. There's some great research on like lutein and zeaxanthin, some of the pigments in like our kale and spinach and a lot of our really green pigmented foods that can that are
Mm.
really strong in women, but really a
Okay.
diverse eating the rainbow, a diverse diet of antioxidant rich foods is probably the best place to start.
Eat the food, people.
I know, I know. Food is
Thank you.
powerful.
Yeah, it is. It is. And I think, just going back to our roots and really just, thinking basic rather than,
Yes,
something fancy, more expensive. I think, we need to change our mindsets also. But
yes,
again, with everything else, as you know, Michelle, just on social media, these fads and diets and all of these supplements that are being advertised, it does play with your mind.
it
So
does. It does.
yes, it's a challenging environment that we are living in.
Yes.
Yeah, but a great question again. So another one on so soya. We have a few questions I think on soya. So does soya flavons and evening primrose help to overcome hot flushes and some of the symptoms of menopause? What is your
Yeah.
experience with that?
So yeah, the evening primrose and some of the supplements, again, not great evidence when we look at it.
Right.
It's not extremely powerful. Obviously, hormone therapy for those who choose to and can safely use it is powerful. But
Mhm.
soy does have some really good research behind it. Not strong enough studies yet where it's like a formal recommendation. But Neil
Mhm.
Barnard with the Physicians Committee for Responsible Medicine has a great study where he had women do a randomized trial where they had a group do a half cup of cooked soybeans daily and saw a
Okay.
significant decrease in severe and moderate intensity hot flashes. I don't like, so the soy food interacts with the receptors differently than the soy supplements. So
Okay.
I recommend soy foods,
Soy
one,
foods.
yeah, 1 to 2 servings a day and not the soy supplements, because we don't know what those are doing to all the estrogen receptors. But those soy foods work for some people. We think there are probably differences in the microbiome, so they don't work for every woman. But for
Mhm.
many women, they see significant results. So I think it's worth a try. And even if women don't get benefit for hot flashes, the soy foods have tremendous other benefits.
Great. Thank you. Okay, so there are some questions on fasting, so and related to menopause. So is there any evidence to support the use of fasting to decrease the intensity and frequency of hot flashes?
Yeah, so great question. Lots of dialogue about fasting.
Hmm.
And I would say in general, looking at the general research, there is not literature to support fasting for decreasing menopausal symptoms or even for
Okay.
significant improved health in the general midlife woman population.
Okay.
However, there's really great evidence coming out about chrononutrition. So some people say like that's I wouldn't consider that fasting though. I would consider that like time restricted eating where you're really
Right.
trying to eat from when you wake up in the morning and then really stop a couple hours before bed. That actually helps with more deep sleep. So not fasting per se,
Okay.
but just kind of like timing that eating window. Some good research there.
Okay, great. I mean, I'm just going to again ask those questions just so you can add your insights to it or
Of
and
course.
provide clarity like you just did. So,
Yes.
how does regular intermittent fasting, 16 hours equals to or more, fit in with a plan for menopause transition and healthy aging, if at all?
Yeah, yeah. So I think and that there's not like really a defined window. Like when we
Yeah.
look at the literature, there's not really a like an optimal this number or this number. Really, we see that just trying to shift more of our calories earlier in the day when glycemic
Mhm.
control is better. So we can take the same meal and eat it early in the morning and late at night, and we'll see a much bigger glucose response, glycemic response from the late night one. So really just trying to shift more of our calories during the day when we're using and burning energy. I would say that's where more of the research is. And if somebody feels good doing 16 hours and doing their eating hour window of 8 hours, I think that that's fine.
Mhm.
I don't think there's strong literature showing that we have a specific number, just more of that timing it during the day and avoiding the late night eating. So many women, myself included, can find it really easy to get busy during the day. We're busy working, doing all of our different
Right.
things. And then we come home at night and we're hungry. So just really trying to think about nourishment throughout the day.
Yeah, I think that's a very good point, and especially and honestly speaking, I sometimes tend to do the same,
Me
because
too.
I just come home, now I can rest, eat. So yeah, maybe I do
Yes.
eat more calories, in the evening,
Yeah.
which
So
is
one
which is
simple
not the correct
Yes,
way
but
we should
so
be
easy to
eating.
do. Yeah, so
Yeah,
easy to do. So
yeah,
one of the things that I do is I start my day with a morning smoothie. So this has
right.
kale or spinach. I do blueberries. So again, I'm getting some real high
Okay,
quality foods. I do ground flaxseed in this. I do
right.
some I do
And
some
that, and we got
plant-based
several
yogurt
requests. We got several requests for the smoothie. So good, you're telling us
and
the recipe.
cinnamon, so
Can
antioxidants
you
and
just
some
repeat
soy
it
milk.
again? Can you just
Yes,
repeat
and
that
I'm happy.
again,
I actually have a
please?
lot of things in this. I'm happy to give it
Oh,
to you and you
okay.
can distribute it. But soy milk, so I'm getting the soy, ground
Soya,
flax seeds.
ground
I have
flaxseed.
some leafy greens, so like
Okay,
I use frozen kale or frozen spinach. I do frozen blueberries. I
right.
do some cinnamon, so that's very strong in antioxidants.
Yes.
And then to get some fermented food in. So again, this is kind of like this is like my multivitamin right here. And
Right,
then I
right.
have a good amount of calories and some protein earlier in the day. Soy milk
Hmm.
has some protein in it. And then the fermented food with like some yogurt, I'll put some yogurt in here.
Okay.
So you can really pack a lot in. And then also having like some nuts around. Nuts are so powerful. Not
Mm,
huge portions, but having some nuts so that you
right.
can space those throughout the day. You're getting some protein, some
Hmm.
fiber. So thinking of some easy snacks too that can help shift more of the calories more earlier in the day with some protein too.
Great, thank you. So I hope, our audience got that smoothie recipe. So please do try it and definitely, then let us know how that works for them.
And
Um,
experiment with different things, whatever I
yes,
have around, throw things in and don't be afraid of frozen. Like many fruits are like
right,
picked at their prime. So frozen
right.
fruits, keep them. And then also what you can do is you can I mix together my smoothie batch for the whole week over
Mm,
the weekend. And then that way I can
okay.
just dump it in with some soy milk early in the morning and
Yeah,
make it even
yeah,
easier. So finding ways to make this as easy as possible.
right. Yeah, that's wonderful. Okay, so since we spoke a little bit about soya, there was another question saying that just wanted to clarify, half cup of soya beans daily are safe for breast cancer survivors. Is it safe for women who are at high risk of breast cancer?
Yeah, so there's been research on soy. So again, I would say not soy supplements, but on whole and minimally processed soy foods that
Okay.
probably like a serving to two servings a day are considered safe and even
Hmm.
beneficial. And then the American Institute for Cancer Research, or AICR, has some amazing research if you want to find out more about soy
Hmm.
foods, not supplements again, foods in women who are at risk for breast cancer. So I'd encourage you to check that out.
Okay, great. Thank you. Okay, so we have another question about what is your advice for a lady who's going through menopause and still working night shifts?
That is so hard. Yes.
Mm,
There's some specific research on night shifts. But I think so there's some kind of it depends. So there actually is some
okay.
specific literature. I would be happy to get that to you and you could pass it along. But really trying to do some things to optimize sleep as best you can then. And as somebody who's I don't deliver babies anymore, but for years I had the craziest sleep
Yes.
schedule. So I
Yeah.
can relate, but really trying to do what you can to protect sleep. It depends on if you're shifting back and forth between different schedules or if you're always on a night
Mm,
shift. Some
mm.
different things you can do even with like daylight or even some of like the light boxes. If you don't have access to the bright morning light during the day because of your time being off. So I would say it's kind of it depends on the situation, but there is some good literature I'd be happy to share.
Yeah, great. Thank you. So, Michelle, we do have a few more questions. Would it be possible for you to stay on for
Oh my
five,
goodness,
8 minutes?
of
Okay,
course, of
great.
course.
Thank you. Because, I definitely, like it if these questions are answered for our
Oh my
audience.
goodness, yes. And people can
Great.
reach out to me afterwards too at my email.
Sure.
I am happy to
That's
take
very
questions.
kind of
This
you.
is my
Yeah, that's
passion.
very Great. Okay, so the question is, how can lifestyle medicine be practically integrated into routine care for women going through menopause, especially in settings with limited time and resource? I think this is a question we get again and again and again. Whenever we do courses for healthcare professionals, this is one of, the biggest. But I think this is a global problem, not only for Qatar. I mean, in the
Oh
US, it's
no.
a time constraints everywhere. The business models are running. So, what are your insights, Michelle?
Yes. Oh my goodness. Yes. Thank you so much for that question. So I'm actually on sabbatical from my university this semester, and that's one of the areas I'm trying to
Mm,
target is how do we help get this information out? One of the most
okay,
so I think at individual appointments we can do what we can, but again,
right.
so challenging. One of the things that make me the
Yes.
most excited though are the possibility of group medical visits or shared medical appointments.
Mm,
And even like there's research on doing Zoom gatherings where we have maybe 20 or maybe even we haven't done research on like larger groups, but we gather women together in a community where we have someone, a clinician. So once again, the research really shows that if we can have clinicians delivering evidence-based information around menopause and then have people gathered in community, that's really that sweet spot of community, lifestyle
mhm.
medicine, and then having a clinician involved. So I think that
Okay.
that's probably where the next year makes me really excited is I think that we'll see more and more resources to support people, support clinicians who want to lead shared spaces to do some of
Mm,
this. So I think we need
mhm.
to think creatively, in addition to continuing to do what we can in our clinics and creating more resources through the Lifestyle Medicine Global Alliance or the International Board of Lifestyle Medicine or the American College of Lifestyle Medicine. We're going to try to make more resources and get more information out there. But I really see that shared space as a
Mm.
powerful opportunity where maybe we, once a month we have a gathering where we invite women to join something and we have some education and then time for dialogue too. But I agree, it's a challenge globally. It's a
Yes.
challenge globally.
Yes. And I think, again, like you're saying, little steps, whatever we can, make those in ways wherever we can, and we'll get
Yes.
there.
Yes, yes. And then also, I think too, realizing the power of our voices, letting people know, because there is so
Right.
much misinformation out there, at
Mm,
least in the United States. Take this supplement, do this special routine, do this
it's
special diet. And it's like, oh
everywhere.
my goodness, no, just eat healthier foods. Don't calorie restrict significantly. Eat. So I think that us helping give a voice of reason too, to say there is real power in food as
Mm,
medicine and movement as medicine. And so I think us using our voices to say this is powerful, try to turn away from some of the other hype and just follow the true public health,
right, right,
I
right.
think can be really
Yeah,
powerful
yeah,
too.
I think that's great advice. Another question about protein. So we have somebody asking, boiled eggs are one of my preferred proteins. How many can I have per week as a menopausal woman without impacting cholesterol levels? So what are
Yeah,
sort of the recommendations, per week? How many can we have?
yeah,
Uh,
I don't. Yeah, great question. I don't know
yeah.
of a specific number per week. I attended
Yeah.
a Harvard Grand Rounds recently where they had someone
Hmm.
speak about some new research out about eggs, and so
Hmm.
I would say there's not great
Yeah.
evidence as
Yeah,
far
I
as
think
midlife women, but
right.
limiting.
I
I
mean,
think
I've
some are
I've heard
fine,
in general
not
3 to 5,
excessive.
it's not now related more that was like old, that it messes up
The
with your cholesterol. But I
cholesterol.
think keeping sort of, in moderation, 3 to 5 in a week, that's what I've heard also. Some
Too.
other recent literature saying should be okay.
Yes,
But
yes,
again, getting your annual checkup, keeping a check on your cholesterol, I think that's definitely a good idea also.
most definitely.
Yeah. Okay, some more questions. Any tricks for navigating perimenopause, fatigue, plus sleep apnea?
Oh,
Previously compliant patient, now falling asleep without the CPAP due to high levels of fatigue and falling asleep in other places like the couch, etc. Uh,
yeah.
what are your thoughts on that, Michelle?
Yes, yes. So fatigue is one of the biggest issues we see. I mean, we talk about hot flashes all the time, which of course we need to take seriously. But
Hmm.
that fatigue is a significant issue for so many women. One of the things that we notice in menopause is that many people pull back from physical activity. We actually are starting to get some research now on the hormonal changes may decrease some motivation. So it makes it even harder at the time we need physical activity the most. We it can be even harder for us to do that. But we see the decline in mitochondrial efficiency and number. And
Mm-hmm.
so we need physical activity more than ever. Like the research around physical
Okay.
activity has been what has surprised me the most in these last like 5 to 10 years. So if we can get women doing like even a little bit of resistance training, like I keep these bands by my desk, I can use those. But if we can get them doing a little bit of resistance training and some movement to help
Mm,
increase their mitochondria, usually that significantly helps with fatigue. And then eating regularly throughout the day. So many women start to gain weight, and so they think, oh my goodness, I'm gaining weight. I'm going to do what I've always done. I'm going to decrease my
yeah.
calories. Well, then it makes fatigue even worse. So really
Right.
trying to get them to like fuel, nourish their body throughout the day, and then get in, it doesn't not need to be a ton of exercise, but get in a little bit of physical activity during the day too, I think would be the most powerful. And then yes, treat sleep apnea. Yeah.
Yeah, yeah, it's a tough one. Okay. Just little questions on like, what do you think about fenugreek seeds? I don't know if you want to, say anything about that for menopause again.
Yeah,
Um,
no, that's yeah, I
mm,
haven't I haven't done a literature review
yeah,
on that area recently, so I don't know if there's anything new out. In
right.
the past, my understanding was there wasn't a lot of evidence for it having a significant impact. Um,
Hmm.
but again, I haven't done a recent literature review.
Sure.
In general, supplements for menopause symptoms don't seem to be that
Mm.
beneficial. Really, we see kind of the best when well, of course, with hormone therapy for those who try to use it or want to use
Mhm.
it, or there's some other prescription medications as well. And then the general lifestyle.
Great. Michelle, a few questions about brain fog.
Oh,
So,
yes.
yes, so if you can just talk a little bit about that, definitely, because I mean, there are a few questions I see, women multitasking, facing severe brain fog, then depression happening. How can we help? And even if somebody is going through menopause, brain fog, and what do we do about it?
Yes, yes. Oh, great question. So I love that. So Lisa Mosconi is an amazing researcher. So I
Okay,
love her work, and she has some great even
great.
like patient-facing resources.
Mhm.
But I think first telling patients you're not alone. This
Right.
is normal, and it often is starting like now that we're seeing that menopausal symptoms are starting for many women in their late 30s and early 40s. So letting people know that they're not alone. It's their brain readjusting to how like the glucose metabolism shifts, and so it's the brain readjusting. So letting them know this is not permanent. It does not mean that something's wrong with you. So I think that just that compassion and that asking them to be gentle, but also it's a sign that the body needs more self-care now. That we
Hmm.
need the body doesn't become fragile, but I think that vulnerability, like we really need to care for the brain. And so doing everything we can again as far as food throughout the day, like we do not want to start out the day with not having any energy. So we have a bigger cortisol
Right.
spike and then more energy crashes and more brain fog, but really realizing the fuel throughout the day. And great research again on resistance training. So I am not somebody who likes to go to the gym, but the
Yeah.
research on resistance training has been so incredibly powerful, and especially some research on brain health that it's made me go. I'll be going to the gym later on to work out with my mom in just
Hmm.
an hour or so. So yeah,
Great.
so that's why I would say is
Sure.
focus on those things and then sleep. Often there's so many different things together. And that's where if somebody's having severe problems with sleep due to night sweats, I do think that hormone
Mm,
therapy is a beneficial treatment for some women. Of
right.
course, if they've gone through it with their clinicians and it's safe for them, because when we can address the sleep problem, for many women, that brain fog is helped as well. So kind of that multifactorial
Right.
approach and letting women know, like, let's optimize your brain health with everything we can do that help with symptoms now, but also long-term brain health.
Great. Okay, just I'm gonna just ask you a couple more questions and then we'll
Of
end. We're
course.
at far past,
Oh,
we're
I'm
10
happy to see
minutes
this. I
past.
love this.
Oh, great. Thank you so much. Okay, so can women take NMN or NAD supplements for low ATP? I'm not sure, what exactly they mean or if you've heard of them.
I have heard of them, and I'm sure it's a great question. I don't know enough to be able to speak to those
That's
supplements. I apologize.
right. So
Yeah.
another question on does diabetes worsen menopause symptoms?
So we often see, so women with diabetes, we see an association. So how much of that is actually due to it, or is it just the association? But we do see for there's the vulnerability for worsening glycemic control in all women as they go into menopause. And so the same like glycemic load, and we can have a larger change. In patients with diabetes, it's even more important to kind of do all those heavy lifestyle or those significant lifestyle behaviors, and then also to watch them real closely. And again, this is the no shame, blame, or guilt. Like I went through surgical menopause, so it was overnight. And so to see the change in my lipids when I knew I had not changed my diet at all and I was exercising. So to see that change, I think we really need to let women know it's not that you're failing, it's that physiology is changing. And so maybe you didn't need statins before, but maybe you will want them now. Or, there's so knowing that there's a lot that we can do with diet and lifestyle, but also realizing that they may need a different dose of medication or more intensive therapy as they go through the transition. Yeah.
Thank you. Okay, so I'm going to end with the last question, and I know you've done work with the Blue Zone certification also. So, question on life, longevity versus healthy food and Blue Zones. So, can you elaborate a little bit? So, let's give people a teaser about that, and maybe you can talk a little bit about that, and then we will end. Thank you, Michelle.
Oh, of course, I'm happy to. So the Blue Zones were identified by Dan Buettner and a team of researchers, Giovanni Pes and Michelle Poulain, and some National Geographic researchers, where they identified 5 pockets of longevity around the world. So Italy, Greece, Loma Linda, California, Japan. So they identified these areas and they found some common threads between those populations. So they have what they call the Power Nine. And so one of them is a plant slant way of eating. So again,
Right.
what we talked about today, right? Not about being vegan or vegetarian, but really trying to eat an abundance of whole and minimally processed foods. The 80% rule, so they didn't eat huge portions. They ate until they were about 80% full. Getting movement naturally throughout the day. They didn't go to gyms, but I've spent time in the Blue Zones, and they're gardening, they're out there doing their physical activity, and they're just real active throughout the day. Often they're in really steep places. So my family and I have spent time in the Blue Zones, and will often be, somebody who's in their 90s might walk up a hill just as fast or faster than myself with my kids.
Amazing.
So,
Yeah.
and then also one of the things that I think is really powerful with the Blue Zones is we see the importance of connection. So all of these 5 groups had a connection. Most people had a connection with a faith community, all different ones, right? But they had some connection with a faith community, some connection with family was strong, and connection with friends. So we see social connection was a main part of it. And then also purpose. So they really had that sense of purpose. And I think that's something that we can tie into our work too, is it's not just, telling women you should eat healthier because you will decrease your risk of cardiovascular disease. Well, that's not too inspiring. But, for me, I want to eat healthier so I decrease my chances of a cancer recurrence, so I can
Right.
enjoy time with my family, so that I have energy to do what I want to do with my
Yes.
kids. So focusing on that purpose. Downshift is one of the principles. So again, we see many of the lifestyle medicine principles that we went over today in those Blue Zones.
Right.
And so I think that it just really aligns with what we already know with the lifestyle medicine principles, and then pulls in like some of the power of purpose and a connection with something meaning, whether that's volunteering or some type of spiritual practice for those who it doesn't need to be a formalized religion, but something, some type of practice that
Right.
helps one too. So yeah, but
Great.
some really interesting information. But I think
Yeah.
one of the things that's so exciting is that it's not just those Blue Zones. When you travel and you start to look at other research too, you realize that there are other pockets in addition to these 2 where people are eating more whole or minimally processed foods, where they're moving more throughout the day, where they're very well socially connected, and that you usually see some longevity there as well.
Yeah, wonderful. So, Dr. Tollefson, again, thank you. A fantastic session. We've had a lot of appreciative comments for you. So, our gratitude to you for taking the time out for doing this session. I'm sure it's going to be very beneficial.
Thank you for the invitation. I'm honored that you asked me to join you, and please reach
Our
out
pleasure.
anytime. I'd always happy to
Thank you
support.
so
So
much.
thank you for the
And
opportunity,
thank
everyone.
Yeah, and thank you to everybody who joined us today. And we hope, it's going to be beneficial, for the people attending, and then, as they serve their patients and communities and beyond. So thank you, everyone. Have a good evening, and bye-bye for now.